An introduction to critical care, presented by me, your host, Pat Nelligan. In this tutorial, I'm going to discuss the assessment of ventilation in the critically ill patient, and particularly where I'm going to look at carbon dioxide levels in blood and carbon dioxide levels in expired gas. Assessing the critically ill patient. Part 2, pulmonary. Part 2 of pulmonary is assessing ventilation. In the previous tutorial, we looked at assessing the patient's oxygenation status, and the most important component of this is to calculate out the PaO2-FiO2 ratio, and that is a component of the definition of ARDS. I also discussed how pulse oximeters work and how to use the pulse oximeter as a way of targeting oxygen therapy. Finally, we looked at the different types of oxygen treatment that you can give patients: nasal cannula, high flow, and CPAP. In this tutorial, we're going to talk about the monitoring of ventilation, specifically the partial pressure of carbon dioxide in the blood and in the blood gas, and how it relates to the pH in the bicarbonate. I'm then going to move on and discuss very briefly capnometry and capnography. Carbon dioxide is the major waste product of respiration or metabolism. We manufacture about 200 mils per minute of carbon dioxide at rest, but this increases massively with increased energy turnover, particularly during critical illness. The CO2 gas production must always be matched by CO2 gas elimination. The rate of gas elimination is determined by the alveolar ventilation, but we measure a surrogate of this known as the minute ventilation. Carbon dioxide is produced in cell mitochondria, and it diffuses out of the cell into the extracellular space and then into the capillary and into venous blood. At this point, it is principally dissolved in blood or bound to hemoglobin. As CO2 enters the lungs, it encounters a liquid-air interface that is between the capillary blood and the alveoli. CO2 then diffuses down the concentration gradient into the alveoli, and then it passes along the major airways by diffusion and mass movement associated with tidal ventilation, clearing the dead space and then being expelled into the atmosphere. The partial pressure of carbon dioxide at end expiration is the end tidal CO2, or the PET-CO2. Let us now transition these data and partial pressures of CO2 gas as measured in each of these locations. So we start at the mitochondria, and the intracellular CO2 is about 46 millimeters of mercury, or 6 kilopascals. It's more or less the same in venous blood, about 44 millimeters of mercury, and again about 6 kilopascals. In the alveoli, the partial pressure is 40 millimeters of mercury, or 5.1 kilopascals. And then in expired gas, it's about 35 to 38 millimeters of mercury, or 4.8 kilopascals. If you measure the partial pressure of CO2 in arterial blood, it's about 38 to 40 millimeters of mercury, or 5.1 to 5.3 kilopascals. There is about a 3 to 5 millimeter of mercury, or 0.3 kilopascal difference between the end tidal CO2 and the partial pressure of CO2 in arterial blood. It is important to look at CO2 production and clearance as being part of a conveyor belt, a bit like what you'd see in a sushi restaurant. Carbon dioxide is continuously produced by the tissues as part of metabolism at a baseline rate of 200 mils per minute, which can increase exponentially with exercise. A specific proportion of manufactured CO2 must be removed from the blood each minute to maintain a partial pressure of CO2 of approximately 40 millimeters of mercury, or 5.3 kilopascals. What happens if that quantity of CO2 is not cleared? What happens is that the patient develops hypercarbia. The main purpose of ventilation, that is, taking a breath in and expelling a breath out, is to refresh oxygen in the alveoli and the dead space and to expel carbon dioxide. This process requires adequate alveolar gas turnover to remove a minimum of 200 mils per minute of carbon dioxide, and it's known as alveolar ventilation. If alveolar ventilation is inadequate, carbon dioxide builds up in the body, the blood becomes more acidic, blood pressure falls, and the patient becomes somnolent. This may ultimately result in cardiac or respiratory arrest. Why do patients fail to ventilate? The first reason is failure to generate adequate minute ventilation. The causes are anatomical or neuromuscular. The second cause is failure to clear carbon dioxide from the airways despite adequate minute ventilation. By this I mean tidal volume multiplied by respiratory rate. That's what's measured by the ventilator. It's not the same as alveolar ventilation, and the problem is caused by ventilation perfusion mismatch, increased dead space, and auto PEEP. Let's look at failure to generate adequate minute ventilation. We'll start with neuromuscular control of ventilation. Always start with the brain and work your way down. There may be a problem with the respiratory center in the medulla that responds to the partial pressure of CO2 by increasing minute ventilation if the CO2 rises. This can be impacted, for example, by a brain injury, ischemic, hemorrhagic, or traumatic, or reduced responsiveness to CO2 caused by opioids, benzodiazepines, other sedatives, including propofol. There may be a problem at the spinal nerve level, C3, C4, C5, and the phrenic nerve supplied by the diaphragm. This can be caused by a spinal injury, a fracture, a subluxation, demyelination, Guillain-Barré syndrome, a phrenic nerve injury, or indeed a interscalene nerve block. There may be a problem of the thoracic pump, diaphragm, and intercostal muscles. This can be caused iatrogenically by neuromuscular blockade, by myasthenia gravis, by myopathy of critical illness, or just a lot of pain on inspiration and the patient just won't breathe in or out. When you look at the gross anatomy of the respiratory apparatus, there are medley places where things can go wrong. Let's start with the mouth. There can be a problem with the upper airway, tongue, or pharynx. For example, a tongue swelling or a neck or pharyngeal mass. There can be a problem at the level of the larynx, trachea, or bronchi, laryngeal edema or obstruction, vocal cord paralysis, bronchospasm, bronchial obstruction. And if there is bronchial obstruction, it can be in the lumen, in the wall, or outside the wall, or there can be a problem with the chest wall itself, including the abdomen, thoracic cage, and pleural cavity. In this situation, there could be fractured ribs, a flail chest, pneumothorax, hydrothorax, that's pleural effusions, hemothorax, and abdominal compartment syndrome. So there's lots of reasons why a patient can't breathe or won't breathe. Now let's look at the basic generation and movement of carbon dioxide in and out of the blood. Carbon dioxide is produced within mitochondria as part of aerobic metabolism. Oxygen is consumed, carbon dioxide is generated. And then it diffuses out of the cell into the blood capillaries and then into the erythrocytes. They are the red blood cells. Inside the red blood cell, carbon dioxide is hydrated in the presence of carbonic anhydrase to carbonic acid. This really doesn't last very long, and it splits off to release bicarbonate and a hydrogen ion or hydrogen ion equivalent that binds to hemoglobin. So hemoglobin is the major buffer of CO2 as an acid in the extremities of the body. The bicarbonate then passes out of the cell and chloride passes in. This is known as the hamburger shift. The opposite happens within the lungs. Every time I ever give a talk on carbon dioxide, I show a slide like this because it's essential to understand that carbon dioxide and bicarbonate are the same thing. Their concentrations always rise and fall synchronously. If you look at the carbon dioxide content of the body, at any given time, only a small proportion of that carbon dioxide is dissolved as gas. About a third is bound to hemoglobin, and 2/3 exists as bicarbonate. Plasma bicarbonate rises in direct proportion to CO2. It's not some form of renally associated metabolic compensation. If your CO2 level goes up, your bicarbonate goes up, and vice versa. And we can use that CO2 bicarbonate relationship to assess whether someone is acutely hypercarbic or chronically hypercarbic. Why do we measure CO2? We measure CO2 as a measurement of adequacy of ventilation. And we can measure CO2 in two places. The first place is in the blood, the second place is in expired gas. CO2 measured in expired gas is known as capnometry. It's done all the time on every patient who is mechanically ventilated or breathing spontaneously under anesthesia. CO2 measured in the arterial blood is a measurement of the partial pressure of dissolved carbon dioxide in blood. So let's start off with a quick discussion about CO2 on the blood gas. One of the major goals of physiology is to control the carbon dioxide tension in extracellular fluid and the hydrogen ion activity within that space. Carbon dioxide is measured directly and accurately from arterial and venous blood using a blood gas machine. A blood sample is taken, it's injected into the machine, and the CO2 diffuses out of the blood and into the measurement device. The blood gas machine then uses the partial pressure of CO2 that it measures and the pH of the blood that it also measures to calculate the bicarbonate using the infamous Henderson-Hasselbalch equation. I believe that every doctor or nurse working in critical care should know the rule of 40. Now, I will point out in advance that this works better if you live in the world of millimeters of mercury. But 40 represents the number of nanoequivalents per litre hydrogen ion activity at physiological pH, that is 7.4, at a temperature of 37 degrees Celsius. At that pH, 7.4, 40 nanoequivalents per litre, the PaCO2 in millimeters of mercury is 40. That's the equivalent of 5.3 kilopascals. And at that CO2 tension, the bicarbonate concentration is 24 millimoles per litre. There is a dynamic relationship between the level of acidity of blood, the pH or the hydrogen ion activity, the partial pressure of CO2, and the bicarbonate. If a patient hypoventilates, for example, due to opioids or anesthesia, the PaCO2 rises, in this situation from 40 millimeters of mercury to 50, or from 5.3 kilopascals to 6.6. As CO2 is an acid, the hydrogen ion activity increases from 40 nanoequivalents per litre to 50, and the pH falls from 7.4 to 7.32. As there is an increase in the total CO2 content of the blood, there is a modest rise in the bicarbonate from 24 to 25 millimoles per litre. This process is known as acute respiratory acidosis. The pH is below 7.4, there is a rise in the CO2, and there is a rise in the bicarbonate. There are a series of rules that can be remembered to reflect these changes. In acute hypercarbia, the bicarbonate rises by 1 millimole per litre for every 10 millimeters of mercury, or 1.3 kilopascals increase in the partial pressure of CO2 in arterial blood, and the pH falls by 0.08. Conversely, if the patient wakes up with anxiety, agitation, or pain, they may hyperventilate. The PaCO2 in this case falls from 40 to 30 millimeters of mercury, or 4 kilopascals. This reduces the amount of acid in the extracellular fluid, so the hydrogen ion activity falls from 40 nanoequivalents per litre to 30 nanoequivalents per litre, and the pH rises. Simultaneously, as the total body concentration of CO2 falls, there is a modest fall in the bicarbonate, in this case to 22 millimoles per litre. This process is known as acute respiratory alkalosis. The pH is above 7.4, and there is a fall in the CO2 and the bicarbonate. There are also well-established rules for this process. In acute hypocarbia, the bicarbonate falls by 2 millimoles per litre for every 10 millimeters of mercury, or 1.3 kilopascals reduction in the PaCO2. So if the PaCO2 falls from 40 to 30, the bicarbonate falls from 24 to 22. If the patient hypoventilates for a prolonged period of time, days or weeks, then the body needs to make adjustments to restore homeostasis. In this example, this patient has a normal level pH, but the PaCO2 is high. It is 20 millimeters of mercury higher than one would expect. Note that the bicarbonate is significantly higher than expected also. It is 30 millimoles per liter. I have displayed the patient's sodium and chloride. In this situation, known colloquially as chronic respiratory acidosis, the body has dealt with the higher level of circulating anion, that is bicarbonate, by wasting chloride in the urine. That is known as renal compensation. The low chloride and normal sodium being almost pathognomonic of this disease. There are also useful memorable rules. In chronic hypercarbia, chronic respiratory failure, the bicarbonate rises by 3 millimoles per liter for every 10 millimeters of mercury, that's 1.3 kilopascal, increase in the partial pressure of CO2 in arterial blood. The chloride level falls by an equivalent amount to the rise in bicarbonate. So now that we know these rules, we can set targets for specific patients with their PaCO2 when they come to the operating room or to the ICU. When we have a patient in the ICU and we're measuring blood gases and we want to have a CO2 target, we need to know what the background story or the current status of our patient is. So we have a CO2 that we might use for most of our patients, a different CO2 in COPD, a CO2 that we might have to settle for in ARDS, and a CO2 that we wish to have in traumatic brain injury. For most patients, the PaCO2 goal should be 35 to 45 millimeters of mercury, or somewhere in and around 5.3 kilopascals. In COPD, if the patient is a CO2 retainer, we're looking at a whole range of different carbon dioxides, and we need to know where the patient starts, and we often figure that out by looking at the bicarbonate or the chloride level, but it's usually somewhere between 5.3 and 8 kilopascals, 40 to 60 millimeters of mercury. For ARDS, because it's often so difficult to oxygenate the patient and we don't want to damage the patient's lungs with mechanical ventilation, we will often settle for a similarly high level of CO2, and that's known as permissive hypercapnia. But that is not the case for patients with traumatic brain injury, where we want to keep that CO2 pretty rigidly locked in the range of 35 to 42 millimeters of mercury, or 5 to 5.4 kilopascals. And that's because CO2 has a huge impact in cerebral blood flow. For most patients, we're looking at this level of pH 7.38 to 7.42 and PaCO2 38 to 40 or 5.3 kilopascals, and that is an adequate minute ventilation. If the pH is below that and the patient has a respiratory acidosis and the PaCO2 is high, the minute ventilation is obviously inadequate for that patient to achieve their CO2 goal. So we need to make adjustments to get that CO2 back to where we want it at around 5.3 kilopascals or 40 millimeters of mercury with a normal pH. And likewise, if the pH is high and the patient has a respiratory alkalosis, then we need to reduce the minute ventilation by whatever means to get the minute ventilation to the normal range so that the patient's CO2 is normal. Keep in mind that if the patient has a low pH and a low PaCO2, that means the patient is hyperventilating, but they're acidotic. This is likely metabolic acidosis. You will also find that the bicarbonate is probably below 20 milliequivalents per liter, and the base deficit is in excess of -5. In this situation, you want to know what the lactate is, the ketones, the renal function is like, and what the sodium to chloride ratio is. For most patients where you see a high PaCO2, that means inadequate minute ventilation, and you must ask yourself, is there an immediately reversible component? For example, if there is, you might be able to reverse sedation with flumazenil or naloxone, or discontinue anesthesia or reduce the level of sedation, or you might even give the patient a respiratory stimulant like doxapram. If you cannot immediately reverse this, then you need to look at a strategy that will increase minute ventilation and alveolar ventilation for that patient. And often that is the use of non-invasive ventilation. This is a non-invasive ventilator When the patient takes a breath, the machine generates a flow of gas that assists the patient's spontaneous breath and applies a positive pressure to the airway to a certain pressure target. This augments the patient's tidal volume and alveolar ventilation and reduces the PaCO2. The magnitude of the tidal volume is proportional to the inspiratory pressure level in centimeters of water, and the breath may be pressure controlled or pressure supported. We will cover mechanical ventilation in the next tutorial, but at this point I just want to mention that the interventions that are required if a patient becomes hypercarbic. The first question is whether the patient is breathing spontaneously, and if they are, then the patient is not generating sufficient amount of ventilation themselves to clear CO2, and that may be due to excessive sedation, particularly with opioids or with other sedatives. But the support itself may be inadequate. So if the patient, for example, is on pressure support, we increase the pressure support inspiratory pressure level. If the patient is on controlled mechanical ventilation, then the alveolar ventilation needs to be increased, usually by increasing the respiratory rate and or the tidal volume, or reducing PEEP to reduce alveolar dead space. Every patient who is mechanically ventilated in any setting ever should be attached to a device that measures expiratory carbon dioxide. The term you will often hear used to describe this is end expiratory CO2 measurement, or end tidal, end of breath carbon dioxide measurement. It's used principally to confirm that the tube is actually in the trachea, because the only place in the body that CO2 is removed from is the lungs. So if CO2 is coming out of the patient, the tube must be in the trachea. So the presence of end expiratory CO2 demonstrates correct positioning of the airway device, cellular metabolic activity, blood flow from the tissues into the pulmonary circulation or cardiac output, gas exchange across the pulmonary capillary interface, that's a liquid to gas interface, alveolar ventilation, moving gas in and out of the lungs, and the diagnosis of cardiopulmonary disease. In the ICU, this is the typical setup for end tidal CO2. It's connected between the patient's ventilator tubing and their catheter mount, and that's the device there. Gas is sampled through that little tube, and then the sampling tube is connected into the monitoring system. When the patient exhales, gas flows out of the endotracheal tube or a laryngeal mask into a heat and moisture exchanger or equivalent system, where part of the expiratory flow is sampled by a clear plastic tube and delivered to the monitor via a water trap. The monitor displays a graphic waveform of inspiratory and expiratory CO2 and a number indicating end tidal CO2. End tidal CO2 is the partial pressure of CO2 at end expiration. It usually reflects the partial pressure of CO2 in blood. It's often 1 or 2 millimeters of mercury below that, and most of the time in steady state it gives us a good idea of what the partial pressure of CO2 in blood is. If you see a high end tidal CO2, that means that the patient is hypoventilating. A low end tidal CO2 can mean all kinds of things, including poor overall flow of blood to the tissues. This is what a normal capnograph looks like. During inhalation, there is no CO2 coming out of the patient, so the baseline is 0. And then as the patient starts to exhale, the amount of CO2 gradually increases because of dead space. This eventually reaches a plateau, and then the very end point where the plateau meets the downslope is the end tidal CO2. This is what it looks like on the monitor, and this is the point where we measure end tidal CO2. You don't have to look for this, of course, because the monitor tells you what it is. Sometimes you'll see a picture that looks a little bit like this in a patient in the operating room, where the end tidal CO2 increases progressively. And what's going on here is that the patient is hypoventilating, and then gradually their respiratory rate is increasing because the CO2 builds up and forces the respiratory center to react. The one capnometry trace that I think that you should be aware of is this one here, where there's a slow upswing in the CO2 trace, so it goes up gradually doesn't go up in that nice square pattern that I showed you earlier on. And this is a very characteristic picture that you should be aware of, and it represents slow emptying of airways into the main airways, and this is indicative of increased airway resistance. You will see this in COPD and you'll see this in asthma. Let's review this tutorial. In this tutorial, we looked at the monitoring of ventilation and blood gas analysis, the relationship between pH, PaCO2 and bicarbonate. I discussed underventilation and overventilation and discussed capnometry and capnography. In the next tutorial, we're going to talk about invasive versus non-invasive ventilation, controlled ventilation, and spontaneous ventilation and weaning. I'll see you then, and I guarantee you'll learn something. So that was all about ventilation. I hope you enjoyed it. If you did, by the way, there's lots more material covering this topic in my mechanical ventilation course that you'll find on YouTube and on my blog. If you're enjoying these tutorials, don't forget to subscribe to the channel, leave me some likes and tell your friends about it.